So now go to multifactorial inheritance. What is of interest is that multifactorial inheritance causes more birth defects than either cytogenetic or Mendelian. Multifactorial, by definition, has many possible causes. The Mendelian is a single gene. Only one gene can cause the problem. With multifactorial, a number of genes can produce the same disorder. An example of this is our case. A 32-year-old woman who has corrected tetralogy of Fallot. So she had a congenital heart defect when she was born, but it was corrected. She is now pregnant at 18 weeks with a male fetus. She inquires as to the chance that her son has congenital heart disease. Is there an inheritance risk with a mom who had heart disease? And the answer is yes. Multifactorial inheritance is also known as polygenic, which means not just a single gene disorder, but many genes can result in the same phenotype. Causes, 70% of birth defects are from multifactorial. So if you're asked on the exam, what's the most common cause of birth defects, the answer is going to be multifactorial or polygenic. The mechanism is the interaction of the genes with the environment, which means that you not only have to have a genetic predisposition, but you also need to have an environmental milieu which will allow it to be manifested. If you look then at the recurrence rate, it's going to be 2 to 3%. Is that high? No, it's not high, but it is not zero. The examples are NTD, neural tube defects, congenital heart disease, cleft lip, and palate. These are all multifactorial. Neural tube defect is one that we're particularly concerned with. Here we have a fairly severe cleft lip and palate. Here's one which is even worse. These are multifactorial in inheritance. And there will be then a recurrence rate of 2 to 3%, depending on the family history. Neural tube defects, and here we see varying forms. This is a spina bifida occulta. This is a meningocele. This is a meningomyelocele. The first organ system to develop is the central nervous system. Of exam purposes, a good question on the exam would be, how many days post-conception do neural tube defects develop? And that's 26 to 28 days post-conception. How many weeks is that in menstrual weeks? 6 weeks. By the time the 6th menstrual week is over, or the 4th post-conception week, the neural tube defects have already done their thing. And when we look at, for instance, type 1, type 2 diabetics who are out of control, neural tube defects is a primary concern in terms of malformations. By the time you see them for the first prenatal visit, it's over. So if you're going to do prevention of neural tube defects with patients with diabetes, blood sugar control must be started prior to the pregnancy. Here we see an ultrasound of a normal fetal spine, and you can see the parallel ossification centers of the spine. Here again you can see this. This is the iliac wings down here. What do we see here? There's a cystic structure down in the lumbosacral area, and that's the most common site of a spina bifida. Here you can see on ultrasound a normal vertebral column down to here, and then we have the defect, spina bifida. And here we can see the extent of the sac, which is fairly significant. And the most common site is in the lumbosacral area. This can result in a obstructive hydrocephalus. And on head ultrasound, you will see enlargement of the lateral ventricles here and here. The 4th ventricle, which normally you can't even see, is often enlarged. These children will often require a ventriculoperitoneal shunt in order to relieve the pressure from the cerebrospinal fluid. Here we have the typical location for a spina bifida, down in the lumbosacral area. This one is a little bit higher. This is in the thoracic area. And of course, all of the innervation which occurs below this point may very well be affected, and this child will have loss of bowel and bladder control as well as inability to ambulate. Here we have another spina bifida and a little bit closer view of that. Here we have a couple of defects, one which is a little higher thoracic, and this is down in the lumbar region. This is where the defect occurs rather than caudally, cranially. And this is now an encephalocele. And this is an in utero MRI showing the brain tissue which is out in the encephalocele sac. And this is a postnatal picture of this same fetus, although after it's born. The prognosis is very poor once you have brain tissue which has gone into the encephalocele. This is probably the most severe form of a neural tube defect, and this is your anencephaly. And you can see above the orbits, basically there's no cranium and no cerebral hemispheres. This is a lethal defect. This picture shows not only a anencephaly, but also a omphalocele. And what this picture is trying to convey is when you see one birth defect, think of a second or even a third, because they tend to go in groups. So if you see one, then you want to look very carefully to see if there are others. Here we have a fairly severe cleft lip and palate, and you can see also a cranial defect as well. They tend to go along together. Now, how can we help prevent this? One of the ways we can prevent neural tube defects is by giving folate, folic acid. And because the neural tube closes so early, by the end of the 4th postconceptional week, if you're going to do anything to help this, you need to start preconception. All women of reproductive age group need to be on at least 0.4 milligrams a day. If they are high risk, they should be on 4 milligrams a day. And women at high risk would fall into 4 categories. One would be a previous baby with neural tube defect. Number 2, a positive family history of neural tube defect. 3 would be over type 1 and type 2 diabetes. And number 4 would be women who are on anticonvulsants, because anticonvulsants will decrease folate absorption. So they need to be on high doses. And I think we don't do a good enough job to get this information out, particularly to young girls who have type 1 diabetes. Now, the Food and Drug Administration requires now that all pasta and bread products be fortified with folic acid to try to reduce the neural tube defects. And this looks at the average number of neural tube defects a year in the United States before folate was required to be supplemented and after it was supplemented. If you just have the regular diet, you will probably get about 0.15 milligrams of folate, but you need 0.4. Will folate supplementation completely eliminate neural tube defects? No, because there is not only an environmental effect, which is low folate, but there's also a genetic contribution. I'm always concerned about the Atkins diet. When you decrease carbohydrate intake, will you also then decrease folate intake, and what will that do in terms of neural tube defects? There is evidence that women who have babies with neural tube defects may have actually autoantibodies against folate receptors. And the high dose, the 4 milligrams, then overrides those antibodies and can protect against it. Remember, folic acid is a water-soluble vitamin. You cannot get toxicity. If you get too much, it'll just come out in the urine. This, I think, is really an important point. Folic acid not only decreases neural tube defects, but it also reduces congenital heart defects. The first real preventive strategy to reduce the risk of congenital heart disease. And when you look at type 1 and type 2 diabetics, they have an increased risk of neural tube defects and congenital heart disease. And both of those can be reduced by, number one, decreasing the blood sugars into the normal range, and two is folic acid supplementation. When you look at the percentage of birth defects that come from cytogenetic disorders, such as the trisomies, 1%. Teratogenic, 1%. Mendelian, 15%. This is your autosomal recessive, dominant, and so on. But by far, the majority of birth defects are multifactorial, and those are both genes and environmental influences. All right, that brings to an end genetic disorders.